Now it's the time for the panel. Amy Brin is the Executive Director and CEO of the Child Neurology Foundation. She's been working with special needs youth and their families for over 2 decades. Dr. David Charles is the Medical Director at Vanderbilt Telehealth. He's been measuring physician and patient satisfaction with telehealth and comparing results to in-person care. And finally, Karyne Jones is the President and CEO of the National Caucus and Center on Black Aging. It is the only national organization devoted solely to providing effective leadership in making minority participation in aging services a national issue and priority. Big welcome to you all. Karyne, let me just start with you. I mean, I spend a lot of time with my friend Nancy Lamont of AARP, and I always worry about what are we getting right. When we talk about diversity and inclusion, I look at generational inclusion in these questions as a major priority that needs to be more front and center in a lot of these conversations. As we're discussing telehealth's opportunities and telehealth's limits, where does the population, particularly the population of color who is elder, I hate the words aged, but our moms, dads, us, me, where are they in that picture?
And me. First of all, thanks for having me. Well, particularly since we just went through almost 2 years now of COVID-19, telehealth became very, very important in communities of color and certainly for older adults. Obviously, there were some difficulties because, number one, a lot of older adults don't have access to internet either, or they don't know how to navigate that whole process. And so there had to be some quick learning, or you had to have a grandchild or somebody to come over and help you because it was the only way in the beginning that doctors were seeing their patients. So we realize now that, they've been talking about telehealth for a long time. We knew it was there. It just hadn't had the kind of impact and the kind of, reach that it has now since we've gone through COVID. So it's an important measure. It's an important thing that we need to really try to seek, but it can't be effective if we still have areas that don't have broadband access, if we're not being able to give people access to the internet so that they can do these. And then, as we've heard before, it's very important that we don't replace telehealth with actual meeting with the providers, as that communication and that contact are very important to developing trust in the healthcare system.
Karyne, I want to ask you one more notch. I'd love to get David and Amy's reaction to it. I'm not going to mention the pharmacy, but a nationally branded pharmacy I was at, when I was off getting my vaccination, there was a gentleman, I talked to him, he was about 82 years old, but he had his wits about him, he knew what he was doing. And he said, look, he was trying to tell the internist or the person that was sitting in front processing people, I've been told to, call this number. I've been told to get online, which I've been trying to do on my phone, been trying to do it over and over and over again. So this elderly black gentleman had shown up and he said, my wife and I don't know how to do this. And they said, well, just keep, the guy just said, well, just keep at it. And I'm like going, where is the human face here? We're trying to get people of color in the door, to get them in the process. And I guess my question, and it's a little bit of question about where the equilibrium is right, and how do we maintain a human face, a human connection with the people we're trying to serve, as a lot more of it's digital, but we don't lose people in that process. And I mean, this really impacted me, and I got so angry that day, and I mean, this person was given his instructions on how to process people who showed up without an appointment. But I kind of went up as far as I could the chain to help this couple to get their vaccinations, get by. But they just seem to me to be representative of a very large part of the population that sometimes we don't think about when we're thinking about the efficiency. So sorry to get on a soapbox here, but really wonder what you think. And I'd love to go to David and Amy. We have a lot to talk about and cover here, but I'd love to get their thoughts on, who are we leaving behind as we talk about this? But please go ahead, Karyne.
Well, just a real quick thing. You had one person, we had hundreds of calling and saying, I can't navigate the system. I can't get an appointment. I can't, how do I do this? And so access, again, was one of the health disparities that we continue to see in this country, access that wasn't even put in place. It obviously got a lot better as we moved on in getting the testing and the vaccine sites in place and putting them in communities where people didn't have to go through an internet process to get an appointment. So we had a rough start getting, in the beginning, but it got better, and it certainly is good now where people can go and get that vaccine. As far as where we go from here, that's important. We've always had a health access issue, particularly for communities of color. And that's another reason why there's a lot of distrust, hesitancy, and things that we're trying to deal with to make sure that everybody gets this vaccine so that we can get back to real normal lives. And so those are the things we have to take into consideration. You can't just put something out there, but it has to be where you understand that everybody does not have access to be able to get to an internet. And then, of course, the broadband issue is a real problem.
Thank you. Amy, Brin, I'd love to get your thoughts on that. But, as you're dealing with children with neurologic conditions as well, how does that come in? And are there opportunities with these new platforms that are coming on? And we're going to get to David in just a moment. But what are the limits? How to get the right balance?
Yeah, thanks so much, Steve, for letting me join the conversation. So when we talk about children living with neurologic conditions in the United States, we're talking about 20% of our children. And that can be really a range of conditions, from everything from ADHD to autism to epilepsy to very rare medically complex conditions like spinal muscular atrophy. Pre-COVID, our community's wait time to access a child neurologist was 9 weeks. With the advent or the beginning of the greater use of telehealth, that dropped down to a week, with 20% of our families getting access to care that same day. So the amount of access has definitely exploded for our families that are not part of the digital divide. And to be very frank, our healthcare system pre-COVID was fractured. Telehealth has just illuminated another broken bridge for the families that are really living in underserved communities. What we know is those families living in underserved communities, they're accessing telehealth at remarkably lower rates than those in other communities. And not just because they don't have access to technology or broadband, but it's really illuminating new social determinants of health. So if a family, for example, does not have food, they're not going to prioritize accessing their doctor's appointment. Their first worry is, how are they going to access food? And if they don't have the technology right now during a pandemic to access local community resources that have all also gone virtual, that chasm has just, deepened. And so we are really looking at not only how can we help families relearn and be empowered to use the tool of telehealth, but we are also really looking at how can telehealth be, this is a term I like, but be a reset for this population. So like I said, this is 20% of our children, but they're 80% of the pediatric healthcare expenditure. This is a very costly population. So how can we look at the tool of telehealth as a way to not only provide more accessible and quality care, but really actually more cost-effective care?
Amy, just before I leave you and then jump to David to get his insights on this, are you worried that, I don't know how to put this, I tried to talk to Representative Brad Schneider about this, but are you worried that the community you serve can be left behind or displaced as we develop these new platforms? We're talking about how to get the equities right and to create a holistic health system that reaches, everyone where they are in this process. But are you worried that decisions that are being made in the public policy space broadly are going to be detrimental to the community you serve?
So it's almost like you were sitting in my recent board meeting. Yes, we are very concerned about that. When you even look at current legislation that's out, there's a complete chasm when you're talking about the pediatric population, especially the pediatric population with special healthcare needs. The models that are being looked at, it's really about adults living with chronic disease. And it's, as your earlier speaker said, this is not one size fits all. There needs to be a balanced perspective. But really, I would urge our policymakers to please engage with us thought leaders, multi-stakeholders, our physicians, our families, our advocates, our researchers, to understand the complexity of this so we get it right. Because we do have an opportunity as a country to get this right now.
Well, let's jump to David Charles. Dr. Charles, you must have been a very busy guy this last couple of years and seen, a virtual explosion. I mean, it's very hard, I think, to underestimate how massive this has become. And I hear the worries, on the other side of people worrying that the Telehealth Foundation and reimbursability, all of this plugins in terms of Medicare will somehow come apart down the road. And so I know that you're probably there. Tell us the picture from your viewpoint. You've heard our conversation. What are the strengths of these new platforms in telehealth? Where do you think we've got room to grow and improve, and what are the limits?
Well, again, Steve, thanks for including me in today's panel. So, I'm a practicing neurologist at Vanderbilt University in Nashville, Tennessee. And for the last 8 or more years, I've served also as our medical director for telehealth here.
Right.
And as we came into the pandemic, in the United States, March of 2020, within 8 days, we trained over 3,000 physicians and staff in the use of telehealth. And we went to doing more telehealth visits per day than we did in the entire prior year. So this technology obviously has made healthcare accessible to so many more people who have socioeconomic challenges that prevent them from missing work to get to a physician's office can now see their physician or clinician via telehealth and also be able to be there to pick up their child from school or from childcare. Right. So it's been an incredible transformation. But I really agree with your former panel in that not every visit is right for telehealth. I don't think we need a one-size-fits-all system that says every patient has to be seen every certain number of months via telehealth, because that one-size-fits-all system doesn't fit all geographies, doesn't fit all patient types or all age groups. But what we've learned at Vanderbilt is that it's very clear that the in-person visit and making that personal connection with the patient is absolutely vital. Once that connection is made, telehealth becomes an incredible tool to be able to assess patients remotely. I'll share a story with you. So I had a patient, 71 years old, lives 4 hours from Nashville by car. He's had a liver transplant in the past. My team and my physicians were following him for a problem of numbness and tingling in his feet, and he needed an annual checkup for that and a medication renewal. At the end of the visit, I asked him, I said, Mr. Johnson, how did you like having this telehealth visit? And he's like, Dr. Charles, I'm never coming back unless I need to be seen in person. He said, this saved an entire day of my life, 4 hours of driving over, checking into the clinic, being seen for a 20-minute visit, and then the return home. And so for that particular visit, the patient and the physician determined that telehealth was the right choice for that visit. Not for every visit, but for that visit. And the savings and the efficiency are incredible.
It's fascinating, and I want to ask you another question because you sort of got at it. And I don't know, I really don't. Sometimes I ask questions and I know the answers to them. Sometimes I ask questions and I don't know the answers. But I was talking to a pollster, Frank Luntz, and Frank was kind of looking at COVID-19 and vaccine trust and whatnot. And we had a couple of doctors of the Doctors Caucus. So Congressman Brad Wenstrup of Ohio. I also talked to Senator John Barrasso of Wyoming, who were saying, patients out there don't want to hear from the federal government. They want to hear, they trust mostly their local doctor, their family doctor. And I think you find this across different communities in the country. And I guess my question is, I don't know if anybody has measured trust in the telehealth space. How is trust faring in the telehealth space versus in person? Do you have any ideas in that? Any thoughts?
I do. So it's a very timely question. In fact, we just did an analysis on this in our neurology clinics. And what we found was that patient satisfaction and the likelihood that they would recommend their physician or clinician or recommend telehealth, the satisfaction for the telehealth visit is on par, and in some cases, better than the in-person visit. Now, the patients in some clinics, in certain disease states, such as ALS, those that may suffer from MS, they may value that in-person visit more than the telehealth visit. That's why I agree with your other panel that a one-size-fits-all doesn't work for this. But absolutely, the in-person visit is critical to the overall care of the patient, establishing that physician-patient relationship and trust. But we're finding the satisfaction with telehealth is strong. It was strong when this first started in March through May of 2020. We just repeated the data March to May 2021, and patient satisfaction and physician satisfaction is remarkably high.
Well, look, we've got two really good questions from our audience for all of you, but I want to slip in one quick one to Karyne. Karyne, when we talk a lot about the impact on healthcare, I mean, I would ask this of Amy as well, of any population that is not in the mainstream of getting all the services they deserve, but communities that have not for whatever reason, how do we best reach them? How do we best solve this gap? I mean, I talk about this gap where we look at the gap, we study the gap, we see difference in health outcomes and health disparity. What's the silver bullet to fix it? Maybe silver bullet's the wrong metaphor in this case.
Well, it's not a matter of a silver bullet. It's a matter of acknowledgement that we still live in a country where there is racial discrimination, poverty, and all the issues that create what we're talking about in terms of lack of access. So until we acknowledge that everyone doesn't have access to health insurance, everyone doesn't have access to just daily needs such as food and a place to live and what have you, when we acknowledge that and understand that we all have a responsibility to address those, then we can see where the silver bullet is and how we can work on changing that. So, the disparities that we see in health and which affects a lot of things in different society, we're going to see those until we acknowledge the real issue.
Dr. Brin, Amy, I would ask you a similar question. I look at the youth you work with and serve, and it's very moving what you do, and I just find it, I've learned a lot from reading about you and your work. But do we have the right safety nets out there for the young people that have the disorders you're trying to give help and support to, or are there a lot of people not in those safety nets?
Yeah, I would unfortunately say that we have forgotten our children and our youth. And for an advocate, I don't think there's a bigger deal in life to do than to protect and serve the children and the youth of our world. What I would say, though, is I'm a Pollyanna. I believe that sometimes less is more. And I think to really engage with those that are forgotten, whether it's my community or it's Karen's or it's those in East Nashville, it's about collaboration. It's about not owning that the problem is all yours, but to acknowledge we are one and this is a problem for all of us. And how can we collaborate with stakeholders and partners that do have a good, trusted relationship with those that are forgotten and can help us listen and really understand their needs so that the solutions we put forth actually make sense and actually have an impact. These are long-standing issues. There is no quick fix. The only thing we can do, I think, is really to be committed to being good stewards of service and to listen and then to act.
God, I love that. Thank you for that. We've got a question here from Paul Kelly, and I'm going to direct it first to Dr. David. Paul?
Hi, Paul Kelly here with Capital Advocacy and Government Affairs. I want to thank Steve and the folks at Hill Newspaper again for having a terrific webinar. I wanted to ask about hands-on care. So much of quality healthcare is hands-on, and I'm wondering, in the face of telehealth, if there's a way to ensure that we continue to have hands-on care while also not sacrificing any of the benefits and convenience of telehealth. Thanks a lot.
Paul, thank you. Charles, go ahead.
Out here at Vanderbilt, patients and the physicians work together to choose what's the right next visit. Should it be in person? Should it be via telehealth? And if the patient wants an in-person visit, we do an in-person visit, period. If the physician feels that the visit needs to be in person, we do an in-person visit. It's only if both the patient and the physician agree that virtual care would be an adequate way to carry out the visit. And so I don't think either side wants to take away the in-person visit. Here's what I would say. Turn it upside down. What we can't have is payer policy requiring a patient to have a telehealth visit when they want or their physician wants an in-person visit. Right, so that's the policy that I would be most concerned about. I don't think we need the federal government telling us that every X number of days an in-person visit has to occur, because like the previous panel said, a one-size-fits-all sort of mandate like that from the federal government, it's not really practical to implement. So keeping that decision, the in-person visit with the patient and the physician, right? I believe that's where that decision belongs, and that the patient should have the ability to have that in-person visit if they or their physician want it.
So before I leave you, David, I do want to ask you like one little bit, and this may go back to Amy and Karyne a little bit, but I'm being told by my producers we don't have a lot of time. But I just want to tell you, and a lot of people I know, and I'm one of these people, I'm not a health aficionado. I'm not someone who is as literate as I should be. I really depend on doctors to tell me kind of what to do. My level of understanding of a lot, I try to dig in for these, but when I'm, kind of dealing with my doctor, I say, Dr. Patel, I'll do whatever you tell me to do. So there's a lot of power in the relationship that exists with the medical establishment. People are looking for direction and guidance. Maybe that power and that agency needs to shift, but I think it's going to take a while. Is there a problem in the power relationship shifting when as we're looking at this difference between these different modalities in health, or am I Pollyannish, to go back to what Amy said? So,
well, I would say where the biggest shift has occurred is that when the patient and the physician are in the room and the door is closed, sometimes it feels like there's a creepy third person in the room. Someone who is watching the decisions that the patient and the physician are making, and then as soon as they leave the room, they're trying to unspool those decisions. If it's a medication that I've prescribed or a test that I recommend. And so if that patient and that physician just decide they need an in-person visit, then they need to have full access to having that in-person visit. Similarly, if both agree that a virtual visit for that particular day, that particular problem is appropriate, then they should be able to choose that as well.
Well, I'm going to go to Amy and Karyne in a minute. First, I'm going to get a question in from Jonathan Williams in California. Jonathan?
I'd like to ask about the connections between behavioral health and telehealth. We know that we're dealing with significant behavioral health challenges across the country, and virtual care has opened up a whole new set of options providing mental health and addiction support. My system, Sutter Health in Northern California, over the last 18 months, 90% of our outpatient behavioral health visits have shifted to virtual care, and no-show rates have decreased to 5%. I'd love your thoughts on how telehealth is addressing the behavioral health needs in this country, and what do we need to do to ensure that these needs are addressed equitably? Thank you very much.
A terrific question. So the question is really on mental health, where these platforms can help, what the limits are. Let's go to Amy.
Well, let's hope that's one of the resets, because we obviously know there's a huge lack of access to mental health providers. And the backdrop of this is the pandemic, where we saw so many services get immediately cut off before providers could rotate onto telehealth. And so you had families really living with mental and behavioral health issues, particularly in our population, that became even more isolated. And we saw really a dramatic increase in acute events. And so, yes, this is a complete example of how increased access to telehealth and increased access to providers that don't have to reside within the same state, for example, as the patient, creates new lanes of access. I would also, though, again, always advocate that access isn't the only determinant of good care. How are we ensuring that behavioral health interventions are really quality-based, really focused on the patient's needs, and not just determined by some arbitrary matrix? I think when we're thinking about resets, we've got to think about it from access and quality.
Well, thank you. And Karyne, I'd love to get your thoughts in closing in both of these questions, both about, to Jonathan's question about the mental health dimensions of this and how to be smarter, and then finally, about this question of agency, because I imagine many of your members are also trying to sort of navigate that power relationship in a lot of this. What would give them the most help and support?
Well, we obviously were very concerned about our older adults who are suffering from dementia and Alzheimer's, and also the ones just because of the isolation that it created, new mental health problems and issues. So it was a real concern for us. And so telehealth would have played a major role in helping a lot of the participants in our program that we work with. I wanted to, when we talk about the federal government not being able to mandate things, I just also wanted to throw in there that Fortunately, insurance companies need to take a role into making sure that they're not requiring that there be so many telehealth and so many inpatients. It's not always a government-imposed guideline that makes access to these services a problem. And so I just wanted to throw that out there. But we certainly are concerned about behavioral health, how this affects it. And I'm a big proponent that it should be a patient health provider decision on when you go in person and when you can do telehealth, and then we'll build up that trust and stop all this hesitancy that we get confronted with when we have to really deal with something like, let's say, COVID-19. It was just a distrust factor, and we're trying to build up trust between the healthcare profession and also our patients. So.
Well, listen, thank you. And we lost David Charles's connection for a minute, but I just thought we just had a very human conversation about how to get these equities right in the whole health challenges that we have. So I really want to thank Dr. David Charles, Medical Director at Vanderbilt Health, Amy Brin, Executive Director and CEO of the Child Neurology Foundation, and Karyne Jones, President and CEO of the National Caucus and Center on Black Aging. Thank you all so much.
Thank you, Steve. Have a good day.